They are doing all of the things that we said you ought to do in a healthcare system. The only difference is that they are actually doing it. So that the healthcare system in Cuba from the beginning emphasized prevention, early detection, and early intervention to reduce the upstream costs of healthcare. It was made universal, accessible, and available to people free at the point of contact. So essentially, you have a free, universal healthcare system for everybody. Now, it hasn't been easy. There have been many problems along the way, but 50 years later, it has become a model for developing countries all over the world. And not just because of the quality of healthcare, but it is far more suitable for resource-scarce countries than the healthcare systems of affluent, industrialized countries. The first thing that they have done is to put the major emphasis on primary healthcare, so that they have the highest ratio of doctors to population of any country in the world. And they set out from the beginning to train enough health personnel to meet the real health needs of the people. So today there are about 36,000 physicians in Cuba for a population of 11 million. That is one physician for every 378 families. And the distribution of physicians is evenly distributed around the country, so that even in the most distant rural areas, you will have a physician to take care of the population. There are also specialists to back up the family doctors out in the rural areas, and because it's a unitary system, they are able to match the things like medical education and the training of personnel to meet the needs of the healthcare system, rather than it being a random distribution, as it is, for instance, in the US, where you may have vastly too many neurosurgeons trained just because people want to go into neurosurgery to make a lot of money. So you have far too many specialists in one area and not enough in the other, because we don't have a planned healthcare system, we have a random healthcare system. Yes, I mean, so it isn't a sort of cookie-cutter situation where you can just transport the Cuban system somewhere else. But you can take portions of it and transport it elsewhere. We have a project that we've been working on for the last 5 years where we have taken healthcare providers and local community workers from 3 high-risk areas of the U.S., West Oakland, South Central Los Angeles, and an area near Albuquerque, New Mexico. And we've taken teams from those communities to Cuba. They've learned about the Cuban healthcare system after being there for a week, and then they've come back and tried to apply those lessons, particularly the lessons of early detection and prevention, to the communities where they live. And that's been very effective. The same way the Cuban system has been picked up on by many developing countries around the world, not as necessarily a direct adoption of what Cuba has done, but taking the pieces that they felt were relevant. Today there are about 16,000 Cuban physicians working in 66 countries around the world. And they bring and train the local people in the lessons of the Cuban healthcare system and also help to provide healthcare themselves. They pay nothing for their medical training or any of their health-related training. There are a total of 25 medical schools in Cuba. In order to keep the health system decentralized, there are at least 2 medical schools in each of Cuba's 19 provinces. And if you want to go to medical school, you have to go to a medical school in your own province. And this really encourages people to want to stay where in the province where they grew up, the province where they had their medical education, to practice. This prevents everybody flocking to Havana and having, as has been the problem prior to the revolution, of virtually all of the doctors in the country being located in the capital and nobody else having access to physicians. They aren't required to, but every inducement is there to make them want to do it. They have tried to decentralize everything, including specialty training, so that if you want to become a neurosurgeon, you have as much chance of becoming a neurosurgeon in Oriente province as you do in Havana. And so a physician can still rise to a very high level of specialty training by staying where they grew up and where they had their medical training. Yes, this is one of the real problems, particularly in the US, and it comes back to the cost of medical education. It costs a medical student roughly $50,000 a year to get a medical education. So we are talking about in excess of $200,000 by the time you graduate. Most students can't afford that, so they take out student loans. Most medical students, the day they graduate, have a debt in excess of $150,000. I have encountered so many young medical students who, when they started in medical school, were totally committed to working in an underserved area and making that their career. By the time they graduated and had a gigantic debt, they decided the only way they were going to ever pay it off was to go into a specialty that was going to pay them extremely well, even if that wasn't their real inclination, or if they still would have preferred to go into a rural part of the country. So yes, it distorts the whole system, and I think it would be very beneficial to the US to have a far greater subsidization of medical education, and that would largely solve the maldistribution issue.
And do you think?
No, I think there are a lot of lessons, and many of them have been learned. One of them is to really emphasize primary health care. Some years ago, we took senior medical students from virtually every medical school in the US. Those who wanted to go could go to Cuba for 6 weeks on electives to work with family doctors in Cuba. And they came back with a quite transformed view of what they felt needed to be done to provide good health care in the US. And that's had a big effect on the teaching in medical schools in the US, particularly shifting the focus away from a preoccupation with training doctors for specialty care and medical research to seeing being a family doctor as a highly desirable way to make a living in medicine. The Cuban government runs a Latin American medical school where they take students from all over this hemisphere. including giving 500 full scholarships to US students. And there are currently over 100 US students in medical school in Cuba. It's a 6-year program, and they have to be fluent in Spanish before they start, even if it involves an extra year in Cuba. Part of the commitment they have to make is to go back to the community, the underserved community in the US that they came from. And there are roughly 30 that have graduated, who've passed the US licensing exams, and are now practicing in places like West Oakland and South Central Los Angeles and other underserved areas in the States. So yes, I think it is possible to make changes, but it requires a serious, conscious effort to do it. And the Cuban system, aspects of it have been copied by countries all over Latin America and to a lesser extent in Africa.
One last question.
I just think that we need to be less parochial and far more willing to look and learn from the success of other countries, not just from Cuba. The World Health Organization rates the US medical system as 37th in the world. Given the affluence of the United States, there's really no reason why 36 countries should have better healthcare systems than the US.